this is Jessica. She's our model for today. So the cervical spine exam it's really easy. And I think the reason it is because all you really have to do is make sure the neuro's intact. Because the rest of it, you're just guessing. And it's not like the shoulder exam where you've got Job's test and Hawkins and Neer and all these things that can really make a firm diagnosis for you, or at least a reasonably firm. In the cervical spine, it's basically ruling out the really bad stuff and then trying to determine if there's you can get some clue about the source of what, if any, mechanical pain they might have. So what I do, first of all, is I have the patient stand up, and then I have them do a tandem gait. Let's see if Jessica was drinking at lunchtime here. I think she's kind of holding her arms out. She's a little off balance. I do that one foot in front of the other. And take a couple steps. Walk, there you go. Okay, well, go ahead and sit down. So, and that's actually a good illustration. I doubt very much she's myelopathic. But you do oftentimes see, gait abnormalities are very common, and they're usually not due to myelopathy. So I think when you do see a gait abnormality, it's really important to check the long track signs. Just make sure that they don't have any clonus, they're not hyperreflexic, they don't have a Hoffmann sign, etc. So I do that. So that's sort of my myelopathy screen to start out with. And then what I do is I sit down in front of them, have you put your arms on your lap. And this is the Hoffmann sign. I don't know if you can, I can't see that. So basically the way the Hoffmann sign is work is you flick their middle finger, you sort of support it and then flick it down like that. And then if the Hoffmann sign is positive, the thumb will move like this. So move your thumb when I do this. There. That's exactly what it looks like. Gosh, you might be myelopathic. So that's a quick screen. And then, of course, you can check the lower extremity reflexes. I always check clonus. If I'm really concerned that if everything else is sort of going towards myelopathy, I check the other lower extremity reflexes. But I always check clonus. She's got no clonus. And as you know, 1 or 2 beats can certainly be normal, but if they have sustained clonus, that's a problem. So every time I see a patient with neck pain, even most of the time my return patients, I always just do this quick check. Clonus, tandem gait, Hoffmann's, it's all cool, then you know that there's no major problem. So then the next is to test the upper extremity neurologic function. So I just check the deltoids first, so push out against me. Deltoids, good. Put your arms up like this, push out against me. Biceps, pull back. Triceps, put your arms like this, fingers like this. Bend your wrist back. Good, push it forward. So bend backwards, that's C6, wrist extensor. Forwards is C7, finger or wrist flexor. Bend back, bend forwards. Okay, so do that. Check the reflexes real quick. And this, honestly, is not very useful, the reflexes. I mean, if they're asymmetric, maybe it helps you, but as long as their motor is intact, the reflex exam is sort of not that useful. And then I usually use a safety pin to check sensory. Oops. And we'll use this as and I just go around the dermatomes and check C5, C6, C7, C8. Now, if they do complain of a lot of sort of supraclavicular pain that seems to be radiating from the neck, you can also check C4 is going to be around in this area. The other ones are really hard to assess. So we've checked motor, reflexes, sensory. Now we're going to do range of motion. So then I just have them bend their neck forwards, bend your chin forwards as far as you can. So she can go almost all the way to the chest, maybe a tiny bit shy of that. Now go backwards. So her back of her neck is pretty much her occiput is pretty much the back of her neck. And then now I want you to tilt your head sideways. Pretty good, 45 degrees, that's good. Go the other way, pretty good. Okay, now turn your head, look that way. So they should be able to get sort of close to the acromion and come this way. She's a little closer on that side. So again, those movements are really not that helpful because again, it's the pain that they produce that really is what clues you in on what could potentially be the source of their pain. So The other thing we do is palpation, and I'm skipping over the shoulder. Now, obviously, you want to do the shoulder, the arc of motion, and all that stuff that Brian showed you this morning. But any patient that has, for sure, arm symptoms, you want to check the shoulders. And then the palpation is, it's really pretty simple. I just start up at the occiput, and Sure. Like this? Oh, all the way around.
Oh.
Yep. So I just, certain landmarks, you want to palpate along the base of the skull. If they do have occipital neuralgia, sometimes if you press there, you get some pain shooting up the back of their head, but that's pretty unusual. And then go down centrally, check the spinous processes, and actually more importantly with this is probably the interspinous ligament. That's probably a more likely source of pain in a chronic person than the spinous processes for sure. And then I do paraspinal, but again, I don't know if I'm checking muscle or I'm bending the facet joints. It's really hard to say. And then I also go sideways. You actually can sort of feel the C2 joint. The other ones I can't appreciate very well, but I go down and I sort of know roughly where they are, and I see if there's any focal tenderness. And again, sometimes the tenderness is really more over the foramen itself, and we just can't tell the difference. And then just check the trapezius, check out here, press around, feel for bands of muscle bands, and that's about it. That's what I do. So you can turn around, Jessica. So I think the important things about the range of motion testing is what kind of pain is produced. So if they get a lot of pain when they bend their neck forwards, as I mentioned before, that could be due to compression of the anterior structures, but I think more commonly that's just stretch of all the posterior structures. So I think that's a clue if they get pain with bending forwards. Bending backwards, I think could be muscle, but when they get pain bending backwards, I tend to think more of facet joints or foramen, because I think those are probably more at risk with bending backwards. And then bending sideways, or either rotating or bending, doesn't matter. Again, if they get pain on this side, that usually means it's a joint or maybe a muscle. If they get pain on the contralateral side, which is very common, people say it pulls over there, that's more stretch on an irritated muscle, or perhaps even a little bit of stretch on a nerve. The two things I forgot to mention was the Spurling's test. Just have them turn their head to the side, bend it, and if they get pain going down into their shoulder by their scapula, or more importantly down into the arm, that's a positive test. Sometimes you can sort of add a little axial compression to that if they're not quite sure where the pain is, if it's in the shoulder, their arm, you can just add a little axial compression, and that may help clarify it. So that's the exam in brief. Any questions about that? No? Okay, I guess we're done. Thanks, Jessica.